nationally recognized for her research focused on health literacy as a key factor related to adverse childhood outcomes and poverty-associated health disparities. Her work in developing health literacy informed intervention strategies addressing pediatric medication safety, chronic disease management, and obesity prevention, conducted as a principal investigator of NIH, NICHD-funded R01S grants. I understood what that meant, not being in academia, and grants from the CDC and FDA have been recognized as models for transforming the delivery of clinical care and have informed national initiatives. So without further ado, please welcome Dr. Yin.
Hi everyone, it's a real pleasure to be here today to talk to you about one of my favorite topics, health literacy and child health. So we'll be talking about what do we know and what are needed next steps. I have no financial disclosures. All right, so our learning objectives for today are to talk about the implications of health literacy in the context of pediatric health. Secondly, talk about health literacy-informed strategies and interventions that can lead to improvement in child health outcomes. And last, to learn about incorporating these health literacy-informed strategies in your daily lives. So I like to usually start with a little bit of a story about how I got started in my health literacy journey. And it started about 15 years ago when I was a pediatric resident at NYU School of Medicine, which is affiliated with Bellevue Hospital. And many of you may know Bellevue. It's one of the oldest public hospitals in the country. And it was in that setting where I was seeing so many communication issues. And it was the stories of the families that I saw that really helped inspire me on my health literacy journey. And at that point, I hadn't even heard of the term health literacy. The story of a Mexican mom of a 7-month-old in the emergency department for their 3rd visit in a month for recurrent febrile seizures, and the mother is given 1 drop instead of a dropper full of the semen of them. The Tibetan father who stopped giving his 6-month-old antibiotics for a urinary tract infection for a couple of days because his child was feeling better. He wanted to save that medicine, and the child ended up getting admitted for IV antibiotics and kidney infection. So that's when I started learning about this framework called health literacy. And when I think about health literacy, I think about health literacy being at the intersection point between what the patient and the families bring to the table and the demands and complexity of the tasks that we as healthcare providers, as health professionals bring to the table. So why do we care about health literacy in children? The issue of health literacy is very prevalent broadly and with parents as well. Even though the percentage of parents with low health literacy is slightly less than the general population, a significant percentage of parents are affected. And with children, parents are typically a proxy, especially when the child is young, for health-related issues. So you can see here in this pie chart, the levels of people in the below basic and the basic pies, the red and the orange, is about 30%, and that represents about 21 million U.S. parents. And what's, I think, even more important to point out is this green part of the pie, right? Only 15% are at that proficient level, so that means that the vast majority of parents are facing health literacy issues. Now, health literacy can vary in terms of context. I think we are all aware of that. And for example, I'm going to point out that the levels of low health literacy may actually be higher in the emergency department. You can see that 50 to 80% of low health literacy is found in a number of different studies, and that may be related to issues such as stress impacting someone's health literacy. It may be related to issues with poor understanding of illness severity, bringing them into the emergency department, perhaps unnecessarily, and also issues of poor access to care. In children, the issue of health literacy, in terms of rates of health literacy, has not been that well studied, in part because there's not a lot of measures for health literacy in children. Some people have used things like the newest vital sign, and you may be familiar with that measure with young children as young as 7 years of age, showing that they don't have great health literacy, but perhaps that isn't really the best measure of health literacy. So that area is really in need of greater research and development. In terms of the factors that are associated with low parent health literacy, those factors are very similar to that of the general population. This is some data that we looked at from the 2003 National Assessment of Adult Literacy, looking at factors associated with low parent health literacy, and you can see things like low education, race, ethnicity, being U.S. born, having limited English proficiency, as well as low income, are associated with low health literacy in adjusted models. So there's a lot of different models that we can look at to think about how we get from low health literacy to child health outcomes. And I definitely want to credit my colleague in the audience, Andrea, who's here, with thinking about and coming up with this model and adapting from other models out there, thinking specifically around child health. As you can see, there's an intersection between the healthcare system and the other factors in the environment, like the educational system, community systems, public health programs, etc., that then intersect with the child and the parent and their predisposing characteristics, and it affects the parent or child's health literacy skills. And those skills are similar to what you're thinking about for the general population. So it's related to pre-existing knowledge of the healthcare system and health, their verbal communication skills, their written communication skills, their quantitative health literacy skills, as well as their navigational or information-seeking skills. Knowledge, health behaviors, and self-efficacy, their attitudes and perceptions, and then ultimately child's outcomes. So what do we know about health literacy and child health? Well, recently, with some colleagues, with Andrea here and Alex Glick at NYU, we did a study, a review article for Peds in Review that's in press now, where we looked at the impact of low health literacy on knowledge, on behaviors, as well as outcomes. So you can see that low health literacy is linked to less topic-related knowledge, so related to, for example, medications. We'll talk a lot more about that. But decreased knowledge, for example, that medication dosing is based on weight as opposed to age, preferably less knowledge around medication labels, asthma knowledge, injury knowledge as well, sickle cell disease knowledge, as well as knowledge around genetic screening. So not all that surprising, very consistent with the adult literature. The peds literature has kind of lagged behind some of the adult literature, but in the past decade has really exploded in terms of the amount of studies that are being done. So in terms of behaviors, we're seeing that low health literacy is linked to worse safety behaviors, including things like firearm safety, home safety, including things like setting the water heater to the right setting so it's not dangerous for children. There's worse feeding behaviors, so increase in formula feeding over breastfeeding, for example, less paying attention to things like satiety cues. They're less likely to take action to promote healthy weight. So, for example, they're less likely to have healthy intake of fruits and vegetables, decreased physical activity, there's increased child screen time, as well as decreased sports participation among adolescents. Finally, we're seeing worse tobacco and alcohol-related behaviors, with children being exposed to more secondhand smoke, as well as adolescents having more tobacco and alcohol consumption. There have been links also to increased violent behavior, especially with adolescents. Increased medication use, so we'll talk quite a bit about this later, but poor use of over-the-counter medicines, prescription medicines, decreased adherence, issues with dosing liquid medicines are among the poor health behaviors that are linked to low health literacy. There's worse disease management, including related to asthma and diabetes. And then outcomes. So studies have looked at obesity, showing that there's greater prevalence of child obesity if the parent has low health literacy. There's greater depression, and that impacts on child's school readiness. There's worse child-related disease-specific outcomes. So the areas that are most studied around asthma, more school days missed, more issues with asthma control, with diabetes, decreased glycemic control, issues with controlling their epilepsy, as well as poor control with nephrotic syndrome. And finally, greater healthcare utilization. So in the general population, more ED visits, including more non-urgent emergency department visits, and with asthma, more ED visits as well as hospitalizations. So that leads us to, so what can we do about this really important problem in child health? And one area that we're going to start talking about now is interventions. You can see how the interventions fit into this model, impacting knowledge, behavior, self-efficacy, attitudes and perceptions, and hopefully child health outcomes. So unfortunately, the literature here, in terms of interventions, specifically targeting child health outcomes, is not that is not that robust, and we're really in need of more research. But we did come across a number of studies focused on health literacy interventions for prevention, acute care, and chronic care. We'll talk briefly about each of those. So for prevention, there was some work on vaccines, so designing low literacy, easy to understand pamphlets and comparing them to the CDC's vaccine information sheets. I'm surprised that people preferred those and found those easier to understand. Child injury prevention, there's a study called Safety in Seconds where there was a kiosk that provided easy to understand, customized injury prevention information, and again, leading to increased knowledge. For child obesity prevention, there's a number of different studies. I've been involved in both of these, and the first being the Starting Early study, which focuses on the prenatal period and starts out with individual counseling sessions, plus parenting groups after the child is born, plus health literacy sensitive written materials that are given to parents. And we're following a cohort now, and some early findings are related to activity, but we're also seeing some impacts on weight as well. And then finally, the green light intervention, which I'm going to talk really in depth about in a little bit. You can see that it's a primary care-based, well-child visit-based intervention where we've designed these low literacy toolkits, and we've also trained healthcare providers in health communication strategies like teach back and show back and goal setting, and that has been associated with reduced BMI Z-scores at the 6, 12, and 18 months. For acute care, a lot of the studies have been around medication dosing. I'm going to talk really deeply about that in as one of our case studies in a little bit. So I won't talk about it too long, but it's focused on designing low literacy pictographic information that can then be used to improve the counseling that happens, and also training providers in using health literacy informed counseling strategies like teach back, show back, and demonstration, and that's been associated with reduced dosing errors as well as adherence. We've also done some research on just pictographic medication labels themselves without counseling, and can that help improve dosing errors, and we have found that it is associated with reduction of large multifold errors. Okay, so ED utilization, there's been work looking at trying to reduce emergency department utilization using a easy-to-read health aid book with common child medical problems and what to do about them. And that provision of this book, plus an educational program, led to reduction in emergency department use, especially with at-risk families. For chronic care, a lot of the studies have been done around asthma. Again, you can see there's some work around video and written formats to improve asthma knowledge. We've done some work at NYU around low literacy, pictographic, and photographic asthma action plans, and that has been associated with higher quality provider counseling, and as well as parent improvements in knowledge of inhaler use, as well as knowledge of preventive medication use even when they're sick. And then for child obesity, there was a community-based intervention that was published in 2017 using a health literacy-informed approach that included classes, workbooks, teach-back sessions, and goal setting that led to improved BMI Z-scores in obese children. So in terms of interventions, again, there seems to be a limited study of health literacy-informed interventions to improve child health, at least in the published literature, and perhaps interventions that are being developed are not being published or not being necessarily couched as health literacy per se, in terms of health literacy interventions. The majority of studies really focus on parents and caregivers and not so much on the child. And perhaps that's because a lot of the research hasn't been done about the development of health literacy across the lifespan and how to address those issues. So that's definitely an area wide open for study. So I'm going to dive into two examples, just so you can get a sense of how I've approached the issue for certain topic areas, and perhaps that's something that can translate into some of the work that you are doing at your sites. So the first area I'm going to talk about is pediatric medication safety. And bring you back to this framework of health literacy being at the intersection of what the parents are bringing to the table and the patients are bringing and what the system is bringing. And I like to use this visual thinking about what a parent is feeling as they're trying to figure out how to give the right medication. What are the challenges, health literacy barriers, and dive into those challenges. So in the clinic, in ED, in the clinical setting, you can see that oftentimes physician counseling is not complete. We're not providing all the information they need verbally, perhaps because we're expecting them to get some of this counseling in the pharmacy or in some other way. And we also know that a lot of providers are not using health literacy informed counseling strategies like teach-back, sometimes because it takes too much time, they don't feel adequately trained to do it. In terms of children, liquid medicines are very common, and dosing tools are important if you want to dose accurately, but we know that in the clinical setting, we're often not providing dosing tools, perhaps thinking that in the pharmacy setting, they might be getting it, and we'll talk about that in a second. Oftentimes, prescriptions themselves are missing information. There's a study across a number of outpatient clinics in Boston showing how often prescriptions actually miss information that parents need. And then written information is often not given out in the emergency department, so then parents don't have a lot of things to refer to refresh their memory about what they need to do. Then you move over to the pharmacy side, and you think, okay, well maybe the patient's being counseled by the pharmacy, but I think most of us are familiar with that scenario when you go to the pharmacy and you kind of waive your right to be counseled. I think a lot of people are not getting counseled. We know from prior research that a lot of people aren't being counseled by the pharmacist. We also know that there's a lot of variability in the way that dosing tools are being provided. Not just whether or not they're giving it, but also when they are giving it, we're seeing that about a third of the time the tools are suboptimal. So they're giving dosing tools that are too big and increase the likelihood of errors, or they're too small, and they're making people use their numeracy skills to add. So that's a challenge. Then we think about the pharmacy labeling and the bottle label, and we know that those labels are often not very patient-centered, very confusing. Things that are bolded and highlighted are not for the patient so much as for the pharmacy. And then the information that's clipped to that medication bag, we're all familiar when we fill those prescriptions. There's a bunch of papers clipped to it. Who actually reads those? And we know from studies that that information is written at way too high of a grade level as well. So lots and lots of challenges that parents are facing, and I think it's helpful to think about breaking down all those challenges and how we might tackle those issues when we're thinking about intervention strategies. So it's really no surprise that dosing errors happen a whole lot. So we've seen studies showing 40% or more parents are making errors with medicines. These errors, administration errors, account for a vast proportion of parental adverse drug events. And liquid formulations are very unique to pediatrics in that the vast majority of young children are being prescribed liquid medicines, and those can be really confusing for parents. Parents don't know that they should use a dosing tool a lot of the time, and then when they do know to use a dosing tool, they may not use that tool correctly. In addition, there's the complicating issue of units of measurement. So we use terms like milliliters, teaspoons, tablespoons, dropperfuls, milligrams, and when they're interchanged and even within one prescription, you can see the prescription says one thing, what gets on the bottle is something different. That is challenging for families. So in thinking about these challenges, we decided the first thing we did was think about how we want to try to reshape what's happening in the clinical setting as one approach, try to improve the counseling that happens. And to design this intervention, we went to the literature to try to think about what sorts of evidence-based communication strategies we can incorporate. So the first part, we wanted to incorporate plain language, obviously. Simple words we know are easier to understand and are preferred. We wanted to include illustrations and pictograms because we know that illustrations can improve knowledge, can improve adherence, can improve self-management skills. We wanted to include dose demonstration because we know that when you demonstrate to someone, that really helps them retain that information better. We also wanted to include teach back and show back. So I think we all know what teach back is, having the patient kind of say in their own words or the parent say in their own words what they understand. And that's considered a top safety practice, has been linked to improved outcomes like improved glycemic control.
But I want to also call attention to this issue of showback. This is from a slide from Mike Wolf's team in Northwestern, who's done a lot of this work with adult medication labeling. So they tested how patients understood the term, the SIG, take 2 tablets by mouth twice daily. And you can see in this graph the breakdown between low, marginal, and adequate health literacy. And then on the x-axis is the percent correct. And when you look at in black, the understanding of label instructions, or where the patient's able to say back the instructions, you can see it's pretty high, about 70% or more, including in the low health literacy group, right? But if you look actually at demonstration, which is shown in the gray, you can see that there's a big drop when patients are asked to actually pick out how many pills in a day that they would give. They were really having difficulty doing that, and the biggest drop was with those with low health literacy. So I really advocate for showback. And finally, in our intervention, we decided to include provision of a dosing tool because, well, we want to make sure parents have the tools that they need to actually measure accurately. So we designed an intervention called HELPIX, and that comes from our Health Education and Literacy for Parents program. It's a health literacy program that was going on in the waiting room at Bellevue Hospital. And we designed these low literacy medication instruction sheets that you can see here. And they're meant to be used as part of provider counseling, as a framework for counseling. And we advocate for doing demonstration, show back, teach back, providing the dosing tool. It's only meant to take about 2 minutes for those clinicians out there who are going to say, oh, this is going to take me too long. We tried to keep it really short, and it's not meant to add time to counseling, but really to make existing counseling that you would have done more effective. So you can see this is the sheet that we think works the most effectively. This sheet is called the reminder and tracking sheet. So you can see the dosing diagram, which shows within a dosing tool how much medication to give. We list the date and the number of doses. And then we have a log to help parents keep track of that medication, which is specific to the course of that medication. So it starts on a Monday, if that's the Monday it's starting. We asked the parents to engage in, or the providers to engage in a conversation with parents to figure out what's the best time that would work for their family. Also, we have the provider circle the first and last dose and to really reinforce how important it is to take the full course. So we conducted an efficacy study. So we wanted to see if HELPIX worked in the emergency department. We enrolled English and Spanish-speaking parents of young children who were being prescribed liquid medications, and we randomly assigned them to either get HELPIX or to get standard counseling. And you can see there were dramatically improved rates of dosing errors. So the error rate in the standard care group was about 50% of parents making errors. And then in the HELPIX group, only 5% of parents were making errors. So really dramatic. And we were counting a dosing error as being within 20%, being outside of 20% deviation from the prescribed dose. So if they were being prescribed 5 ml, we gave them some leeway. We said if you gave between 4 and 6, that's still okay. But if you're outside of that range, we considered that a dosing error. For adherence, we also found decreased rates of non-adherence, and we defined that as giving within 20% of expected total doses was being adherent. So if they were non-adherent, they were outside of that range, and you can see the non-adherence rate for standard care was 40%, and HELPIX was 10%. So after we were able to see such exciting findings from our efficacy study, we were able to get a lot of support from our NYU IT group to design a web-based application and to be able to link it to the electronic health record at a public hospital. That way, providers could actually generate these HELPIX instruction sheets at the point of care as they were seeing patients. And we thought that was really important because the initial study was really, it was an efficacy study. I was there. It was not in the EHR yet, and it was not part of the workflow. And so this really gave us the next important step, which was to actually study HELPIX within a real-world setting when it was actually being used by providers after we did a very brief training, and we tried to remind them to use it, but it was really up to the providers to use the intervention. We followed them pre and post implementation. And this is at 2 public hospitals, we enrolled 400 pre, 400 post, and we looked at how often HELPIX sheets were generated, so not as high as we'd like, so it was about 60%. We wish it was higher, but we did still see, despite that, significant improvement in communication best practices by providers. So you can see we tracked things like, and this is by report, so that's one limitation, but we saw improvements in the use of pictures and drawings, in dose demonstration, so you can see from 33 to 60%, teach back from 8 to 24%, show back from 13 to 33%, and provision of a dosing tool went up dramatically, 25 to 79%. And we also were able to replicate some of our findings from the initial study that was with the pre versus post implementation. There was 40% error rates, went down to about 16%, and those who especially did well were those who got the HealthPix sheets. You can see a 12% error rate, and even those who did not get the HealthPix sheets actually did better, presumably because there was better communication happening by the providers. So, and I want to point out again the difference between the first study, which was really, that was my fellowship project. When I finished residency, I did a fellowship in medicine, public health research, and that was my project. And I actually basically stayed in the emergency department for extended periods of time and did this intervention. I did every part of the intervention. I made sure I did that show back, teach back, and provision of instrument. This was really a real world situation, and we were excited to be able to replicate a lot of the findings. So I'm going to shift gears and move out of the provider-patient communication space and then talk about some cross-cutting issues with medication dosing and talk about units of measurement. We talked earlier about people using milliliters and teaspoons and tablespoons and all sorts of terms that can be confusing. So we wanted to study what should we do? Should we move to one unit of measurement, perhaps? We needed to think about what studies to do to see if that would be a good idea. We also were interested in issues around dosing tools, how they were designed, including things like the increments of the markings, the size of the tool, the type of the tool, and we were interested in whether we could improve medication labels themselves. So we were funded through the NIH, the NICHD, on a project which we called SafeRx for Kids. This involved 4 different sites across the country, and our goal was to identify best practices for labeling and dosing of pediatric liquid medications. And we did a series of experiments as our first phase, involving over 1,500 families, where we looked at questions, like I just said, looking at units of measurement on the dosing tool and on the label and the implications of that, looking at different tool types, looking at the size of the tool and implications, and looking at pictograms as well. And we're in the process now of doing an actual use study where we've incorporated all of those findings into one comprehensive strategy that we're testing in an emergency department setting. So what were our key findings from this study? Well, we found that ml only was superior than using teaspoon terms, or MLTSP, that led to 2-fold decreased odds of large multifold errors, greater than 2-fold errors. We also saw that, in addition, ml only had a benefit of not encouraging families to use kitchen spoons, because when we use the term like teaspoon, you're kind of telling people, go ahead, reach in and get one of those teaspoons from your kitchen drawer. So we were able to also show a 4-fold reduction when you take that teaspoon off that label. People are much less likely to think about using a kitchen spoon. We also found that syringes were much more accurate than dosing cups. We were able to experimentally show that when you provide an optimal dosing tool, a tool that's smallest size to fit the dose, that doesn't require measuring multiple instrumentfuls of medication, that led to significant reductions in errors. And we were also able to show that the use of pictographic aids, and you can see this is the label that we tested, led to a 2-fold decreased odds of large errors. And when we define large error, it's greater than 2-fold errors in dosing. One of the interesting things we saw as we were doing the experiments was that by implementing these sorts of strategies, you can actually decrease disparities. So here, this is a graphic showing, looking at how parents dosed, parents with low health literacy, marginal in the middle, adequate health literacy. They're dosing with different tools, cup, syringe that's 5 ml capacity, a syringe that's 10 ml capacity. And you can see here, if for a 7.5 ml dose, if you're moving from a 5 ml syringe, which would make them have to add 5 plus 7.5 equals, 5 plus 2.5 equals 7.5, and instead we're giving them a 10 ml syringe, we can reduce the odds of error by 5-fold. You can see here, it still benefits those with adequate health literacy, a twofold reduction in error, but we're actually decreasing the disparity that we're seeing in dosing errors. I thought that was really interesting. We've since published quite a bit related to this study, and what I think is most exciting about this work is that we've been able to inform policy change. A lot of groups now have come on to support milliliter-only dosing, including groups like the American Academy of Pediatrics with a policy statement that came out in 2015, and there's also in the work some policies that are coming out around algorithms for dosing tool provision. How do we provide optimal tools and get people to adopt those best practices? I'm going to move to a second example now. I'm talking about how a health literacy-informed approach was used to tackle child obesity prevention. So as many of you know, there is an epidemic for childhood obesity, and nearly 1 in 4 children, young children, preschool children, are already overweight and obese, and issues with weight in that first year of life are already having implications in terms of obesity in adulthood, increasing cardiovascular risks, and there are significant disparities in who's affected. So we designed the Green Light intervention, and this is an early childhood obesity prevention intervention in pediatric primary care. So the two main components of the intervention are low literacy booklets and tangible tools that are being used as part of well child visits, starting at 2 months of life. And we're really taking advantage of the fact that as pediatricians, we see kids very frequently. So we see them for well child visits at 2 months, 4 months, 6 months, 9 months, 12 months, 15, 18 months, etc. So we're taking advantage of those frequent interactions with a trusted provider, and we're also training providers in health communication strategies, including teach back and goal setting. We evaluated Greenlight as part of an NIH-funded study with low-income Hispanic and African American families. We did a cluster randomized controlled trial, and we followed 850 English and Spanish-speaking families, parent-child pairs, enrolling them and following them from 2 months through 2 years of life. And we were able to see improvements in child BMI Z-scores at 6, 12, and 18 months. So how did we design Greenlight to help providers? We really tried to make this a valuable tool for providers so they'll want to use it. We tried to help providers guide them in knowing the 2 to 3 key evidence-based messages, evidence-based obesity prevention messages that they should focus on at each well child visit. And we tried to guide the providers, really giving them a script to how to communicate effectively with families, how to use plain language counseling, how to use the photographs and the information in the materials to really support their counseling. And we really tried to promote teach back and goal setting. And we wanted them to do this in a universal precautions way with all their families. So I'm going to talk about the toolkit materials and how we designed them. And I'm doing that so that perhaps you might think about how you would think about designing materials for your own projects. So in terms of the Greenlight materials, like I said, we have core booklets for each well child visit, and we have supplemental booklets for other topic areas. We felt that it was important to have other information, but not to have too much information within the core booklet. So we really kept the core booklets to what we thought were the key essential elements, and then the supplemental booklets to provide additional support if needed. And we have tangible tools at certain time points to support the messages that we're giving. And these are available in English and Spanish. And how did we start? So we started first by trying to decide on what the key content was, what the key messages we wanted to include were. So we conducted a systematic review looking at what interventions existed for this young population. And then when there wasn't evidence for the young population, we looked to evidence around older populations and what's worked for them. We then came up with some of our key content areas. And again, this was with a collaborative effort that involved experts, including obesity experts, nutrition experts, literacy experts, pediatricians, et cetera, to settle on some of these key topics, including things like satiety cues, issues around portion sizes, screen time, activity, and nutrition. We looked to existing materials to see if there were any best practices we'd want to incorporate. We didn't want to start from, kind of reinvent the wheel. We wanted to look out there, see what's good, try to incorporate all the best things that we could see into our intervention. And we used the framework. Is anybody here familiar with the SAM framework from the Dokes? Yeah, a lot of hands. Yeah, great. So I credit them with the framework we used for this, building this toolkit, which is the suitability assessment of materials, which seeks to focus on a couple of areas: content, literacy demand, the images and graphics, layout typography, learning stimulation, motivation, and cultural appropriateness. And I'm going to go through how we tried to do that with the Greenlight materials. So in terms of the content, we really tried to keep everything behavior and action oriented. So you can see on the cover it says, "Put your baby on her tummy to play every day." So we try to learn how your baby shows you he's hungry or full. And we tried to really limit the scope to essential information, like I said earlier. And on our cover, we've tried to have three key messages up front, and we asked the providers to try to cover at least 2 of those key messages. And we tried to limit the number of pages. There's a lot of arguing about what would stay in the content and what would not. These are 8.5 by 11 sheets folded in half as booklets, and that was how our parents and focus groups wanted it, as opposed to flat sheets or trying to put things in a binder and add materials. They really wanted separate little booklets that they could carry easily and share with others. These are our core booklets for each of the different time points, and they're actually available online in our website now. In terms of content, we also, one of the recommendations is to include summaries. So we tried to summarize key points on the bottom of certain pages where things were really important with the little traffic light icon. And that really is where we're trying to distill the important information into a few sentences. This is some place where the parents should really focus on, and also where the providers can really focus. For literacy demand, we tried to keep the materials at the 4th to 6th grade reading level. We use an active voice to best engage families, and we use really easy to understand and common words. We spent a lot of time angsting about the language, and I'm sure many of you have done in designing your interventions. For the images, we were really, really careful about using images that really support the text. We spent a lot of time. We knew from focus groups that parents thought that the images were really important, that they wanted these images to help them visualize how they can take action. And so we spent a lot of time looking at stock photos, and also doing food photo shoot when we didn't find materials that were relevant. So for kids, you have to think about the sizes and how to cut up the food and portion sizes. And so we ended up having a food photo shoot to accommodate that. This is one of my favorite pages. This is on tummy time, and I just want to point out how we use the photograph to really support the text. So there's a little guy, who's pushing himself up, looking kind of uncomfortable doing tummy time, and we wanted to show a baby that's realistic, so parents know what to expect. That their baby's not going to look really happy and smiling like in most stock photos when they're on their tummy, but they're actually going to look a little uncomfortable. And so we really tried to focus on the photos. You can see these are some photos that we had of various foods and how we showed illustrations of portion size, and really tried to help parents visualize how they can do the recommendations in their own lives. We tried to think about our graphics very carefully as well, and how we can best effectively communicate key concepts. This page focuses on how much sugar is in a half cup of these drinks, and this is based from some of the work from the New York City Department of Health. They also had a very similar graphic for adults, and so we adapted that for kids. We use color to support our messages, and that was really important. We use the color, traffic light color theme, so the green being the things that are good for your baby, to do with your baby, the yellow, the not so good, try not to do, try not to give, and the red being bad, don't do it. And you can see we use that for the drinks page as well as some other places throughout the booklets. We really tried to keep the layout and sequence consistent. We thought that would be very beneficial for both the providers in navigating the booklets as they're counseling, as well as for parents when they're navigating on their own or trying to show someone else these booklets. And so you can see the covers, you navigate it the same way, and you can see again with the drinks page as well. We also throughout talk about issues like how much, how often, what food, that's in every time point at 2 months, at 6 months, 9 months, etc. We followed some of the recommendations from the SAM framework in terms of typography, trying to avoid the all caps, trying to keep the font size to a 12-point minimum, using bolding and size to emphasize key points, etc. We tried to promote interactiveness in the way that we are presenting certain topics. So you can see here in the section on starting solids, we ask, how will I know when my baby is ready? And there's a little checklist. My baby can hold up his head well, my baby can sit on his own, my baby puts toys in his mouth, etc. I'm really trying to stimulate interactiveness. And then finally, we have goal setting. On the back of each of the booklets, we have a goal setting page. This is where we want the parents to set a goal. We want it to be parent-directed if at all possible, and they're meant to be doable, baby step goals. And we ask the providers to try to make that goal as specific as they can, to give a time frame, to write it down for the families. And we give some examples, and we really prefer that parents are that the parents are setting their own specific goal. And then here's an example. Monday and Tuesday of next week, I will give juice at lunchtime only instead of at lunch and dinner. So very small baby step goals that are doable so that they can then build on it, make other baby step goals until they can finally achieve larger goals. We spend a lot of time thinking about cultural appropriateness, so choosing very positive images. We thought a lot about the types of foods to incorporate. We spent a lot of time piloting and interviewing parents and staff. We went through a translation process that included a committee approach and did back translation as well to really try to make sure that our booklets were appropriate. Here's some snapshots of our tangible tools. You can see here at the 2-month visit, we're trying to reinforce the juice issue. Believe it or not, a lot of parents are giving juice at 2 months. So we want to try to stop that from parents from doing that. And so we have a little onesie that says, "I'm sweet enough, please no juice," which is very cute. We have 9 months a sippy cup to try to get people to move from the cup, move away from the bottle to the cup, and to put water in the cup. And at 12 months, we give out portion-sized snack cups to really help parents think about the right portion size, also to help support parents so that they can, be out on the go and have snack cups with them that are healthy. And then finally, at 15 months, we have a placemat to really reinforce the plate method and to use the fist as the right portion size. For healthcare provider training, we had a 2-hour initial training on health communication strategies and introducing the green light booklets. We then had booster sessions every 6 months. We really tried to focus on skills, having them use the tools, get familiar with the tools, do the teach back, do the goal setting, so that they can feel comfortable. We also had an observation and certification process, so we watched them using the toolkits to see and make sure that they're able to utilize all the skills we're recommending. And we tried to ensure that Greenlight would be integrated as part of routine care. So we have all the parents getting the toolkit, even those who were not in our study that we were following. And then even when the study was over, parents are still getting the Greenlight toolkit, which is fantastic. And we tried to pitch Greenlight and get to sell it to the providers and sell the benefit of the providers to show them how it could really make their lives so much easier and really make their counseling much more effective, so that when the parents come back, they're not still having some of those behaviors you wanted them not to continue, but to really have their counseling impact behavior change in the families. We've since adapted Greenlight for Chinese families as well. This is with some funding from the NYU Community Service Plan and in collaboration with the Charles B. Wong Community Health Center, which is a federally qualified health center in New York City's Chinatown. And so we're in the process of implementing there and evaluating there as well to see its impact in the Chinese American population. We also recently got some funding from PCORI to look at Greenlight 2.0, so take all the key learnings from our first study, try to improve our toolkit, and also to look at a technology-enhanced version of Greenlight where we're able to supplement goal setting in between well-child visits to support behavior change. And we're really excited. Parents will be able to, it'll be a text-based intervention, and also parents will be able to get a dashboard to follow and track their child's progress. So I'm going to move to our final part, which is what can you do? How can you use this health literacy-informed approach to improve child health in your own practices, in your own sites? So one is obvious intervention, program development. I hope some of the things that we talked about today you can bring back to your own sites and think about how you might develop a program or an intervention or incorporate some strategy. There's a lot of research that's needed. So those of you that are researchers out there, we need more research on health literacy-informed interventions and what works and which interventions should be scaled up and how to scale them up. We need interventions on health literacy training and education. We need research on looking more at health literacy and child health and what are the key areas that we want to target for intervention. Like I mentioned earlier, there's a lot of need for measurement research in child health literacy and thinking about health literacy development through the lifespan. Really not much done in that area. There's a lot of need for advocacy and policy. So some of you out there are positioned to try to push for a change, for policy change. And so you can help to highlight problem areas, to figure out where the gaps are in the data that can drive the policy and take action. And then, of course, there's organizational change. You can try to change where you're at in your organization. You can change your individual practices as well. And I think in terms of individual practice change, I mean, there are a number of principles that I think all of you are probably familiar with since you're all at a health literacy conference. But you can change your own practices and how you're communicating using the key evidence-based verbal communication strategies, using plain language, chunking information, thinking about how you can incorporate demonstration and teach back into your practice. With written information, choosing low literacy written information if you can't design them yourself, choosing what's out there. Or actually, I think that's the best things. First, look and see what's out there before you develop something new, and try to choose things that are low literacy, that focus on the need-to-know information and not the nice-to-know, something that uses purposeful illustrations. And even if you have no access to handouts, you can always draw. That's always helpful, and draw things out for families because written information can really help with communication. Finally, in terms of analyzing written materials, there's a lot out there in terms of how to assess readability, lots of readability calculators that are available. You can even use Microsoft Word to assess readability. But I think for those of you who are not aware, you just have to be a little bit cautious about interpreting Flesch-Kincaid levels. Sometimes that underestimates the reading level. So for those of you who may not be as familiar, it's safer to add 1 or 2 grades to Flesch-Kincaid. And then finally, going beyond readability is really important. A lot of people just assess readability and they're like, okay, checkbox, I've got low literacy materials, and that's actually not the best idea. So we suggest using tools to look at understandability, to look at actionability as well. So for example, the AHRQ has a great assessment tool called a PMAT that can be very helpful. Finally, there's lots of places where you can get plain language information. So you can go online to National Library of Medicine is one source where you can go on Medline Plus and get some information on child health topics. I like to use Kids Health from Nemours. They have a lot of great information that is understandable for families. The American Academy of Pediatrics also has a plain language pediatrics book. They spent some time about 10 years ago where they tried to convert existing handouts into plain language handouts, and it's really great. They sought to reduce the jargon, make it more reader-friendly, have more illustrations that are purposeful. And so this is one example. This is a bedwetting handout that was before it got changed and transformed. You can see how friendly that looks, and you can see the new and redesigned version, which really focuses on what you can do to address bedwetting, for example, how you can keep a star chart, and what to do if you need more help, and there's much more purposeful illustrations there. So just some final thoughts. Clearly there's an established link between low health literacy and child health related knowledge, behaviors, and outcomes. There's limited study of health literacy informed interventions to improve child's health outcomes, and very few targeting children, and that's definitely an area in need of research. There's a menu of evidence-based communication strategies that does exist, which can be incorporated into various initiatives, and I hope that you'll leave this feeling like you can take action to improve child health. So that's all that I have, and I'm happy to take questions from the group, if there's any time. Thank you. Hi.
Hey, Shonna.
How are you?
Two specific questions. Number one, we receive medication dosing information from EHRs where we get a lot of weight-based dosing, and I'm assuming these are from residents who prescribe down to the thousands of a milliliter. And do you believe that it's appropriate to ground them to something that's more measurable? That's my first question. And the second question is, how do you deal with concentration substitution at the pharmacy, where you're prescribing certain volumes at a certain concentration, and they get a different concentration at the pharmacy?
Great, those are two good questions. So the first question about dosing. So that definitely happens quite a fair amount, where, especially when a resident's doing the weight-based dosing and they have it in milligrams, and you can try to just have the EHR convert it to milliliters, and it goes to like 3 digits to the right of the decimal. And I think that it's really unnecessary for most medicines to go that far and to the right of the decimal, and you can't really measure anyway as a parent that far to the right. So I mean, generally, I think it's medication specific, and it depends on the size of the dose and the size, how young the child is. For some of the younger kids, we are prescribing small doses. You may need to go out to a decimal to the right, but in general, it could be really helpful for the electronic health records to round the dosing, because I think that will help parents know how to dose better. So I think there needs to be education from the provider side as well, to look at those issues, but also systems solutions like through the EHR to automatically help people round. Your second question around changing concentrations. So that is an issue, and I think that there's a question of where should the pictogram come from. If you were to give a pictogram for a parent, because at the point of prescribing there may be some changes. It doesn't happen that often. Most of the time the prescriptions do keep the same concentrations when they're being dispensed, but it is true that sometimes they do get changed, and in those cases, hopefully the pharmacy is going to alert the parent to the fact that their medicine was changed, that their dose volume that the doctor said is different than what the patient said. But that's a limitation to the HelpX intervention being given out at the provider setting as opposed to in the pharmacy setting. I think that's why I really am advocating for the idea of pictograms on labels, on prescription labels, because then it's at the point of dispensing, that's what they're getting is this certain concentration, and that's the dose that they should be aware of. Great. There's another question.
Hi, thanks. I really liked the way with the Green Light project you had an intervention in the form of the booklets for the parents, and then also in the form of the training for the providers. So I really like the way you hit both sides of the communication table. And I was just wondering how did you get providers to engage in this and accept this training and use it and give out the booklets, and how did they react to this, and how did you get them to do it? Because I know that's always a hard thing to do. Thank you.
Great, thanks. I think one of the big things with providers is they want to know, the evidence. Why do I need to do this? Is it going to have an impact? What are the issues? And so one of the things we did as part of training was to present them with data about their own patients. What percent of babies are being given juice? What percent of babies don't get any tummy time, et cetera? And using that to try to stimulate the providers to say, oh, hey, I need to do a better job because parents are clearly not getting the message. And this is a tool that I can use to help parents do that. And in terms of the duality of the purpose of the tools, I think, a lot of times we design tools, we think, oh, it's just for the patient, it's, we give it to them and we're done, but it really is a tool for the provider and the patient, because it has that dual purpose because it helps the provider give them almost a script. And we did a study with asthma action plans, for example, where we tested a low literacy action plan versus a standard plan, and we didn't do any training, and we just gave it to the providers, and the providers literally will read off the page of what are the symptoms to look out for, and if you phrase it a certain way, if you give more explicit instructions, providers will execute that because that's what they have to look at, and that's what they're working off of to counsel. And so I'd like people to think about both of those things. And also I think engaging providers in the process of developing and trying to address what their issues are. I think with this intervention, with Greenlight, we really tried to engage providers to see what would be most helpful for them, where are the issues, how do we make this work for you in your workflow. Thank you.
Shonna, we're so glad to have you here in the land of Epic.
Yes, help us.
Right.
I need Epic to help us more with this.
That was I have a couple questions, but my first question is, have you reached out to Epic or Cerner or any of those other EMRs to try to incorporate what you have done and shown to be effective in research and then incorporate it. I mean, I think we need to keep demanding that the EMR works for us rather than accepting what it is. And I like to think that we, because we're Children's Hospital of Wisconsin, I'd like to think that, we have the power to have that kind of conversation with Epic. But I think that it needs to come from many places and many organizations. I don't know. What are your thoughts on that?
So that's a great comment. I've been trying to. It's amazing how long it takes to do something. So we started the HelpX project more than 10 years ago. It took us a couple of years to get the buy-in, to get it, this app built, and then a couple of years to get the EHR to incorporate it, and then to study it. And now we have the data, and we actually got some internal funding to do this in Epic at NYU now. So, and the thought is by designing that process for Epic, they're going to, there's something called the Epic Orchard, where they can then try to share that app with other sites that use Epic, and hopefully disseminate it at a broader level. And then the next step is, how about all the other EHRs out there, and how do you get into those other EHRs? But it's amazing how long it takes, and I think the data really helps to drive movement and get buy-in that is needed. And perhaps if we show the success happening at one institution, we can then use that to get success at other places, and maybe at Epic, the high level, get their buy-in as well.
Does that mean it's coming to us soon?
I hope so.
Okay, good news, good news. I won't take any more time. Thank you.
Thank you.
It sounds like the, good to see you. The green light materials are available online. Did you do anything to tease out how critical the 4 tools are? Is that like a nice supplement or linchpin of the whole, probably not, but I just
That's a great
was interested in
question.
whether you even looked at that, and because that obviously would be difficult for people to replicate.
That's a question that we want to dive into more as we look at the data, is, well, how important is the toolkits versus the the booklets versus the tangible tools, and how many tangible tools, and how feasible is it to scale up a series of tangible tools in addition to the booklets. Those are all issues that we want to tease out going forward as we're thinking about scaling up and dissemination. It's a great question. Thank you. All right. Well, thank you all for your attention.